Good morning if you're just joining us, and welcome to Mental Health Australia's webinar with the Productivity Commissioners Stephen King and Julie Abramson. My name's Lachlan Searle. I'm just going to wait a couple of minutes so that everyone joins us, but we have a number of participants dialing in today for what is a great opportunity to hear from the people who held the pen on the Productivity Commission report into mental health. So I can see we've already got about 100 participants online. We'll wait a little bit more, and I'll talk through some housekeeping before we get underway officially. So thank you for joining us if you've just dialed in, and thank you, of course, to our Productivity Commissioners for joining us today. Okay, we will make a start. As I said, my name's Lachlan Searle from Mental Health Australia. Thank you for joining us. Before I hand to our CEO, Dr. Leanne Begley, I'd just like to talk through how this morning will run. We have over 100 odd participants on the call today, and we're going to use the chat function on Zoom to ask questions. And I would ask that if you ask a question, that it is a question, not necessarily a statement dressed up as a question. Happy to have those statements, but obviously when moderating the questions, it's a lot easier to go through and look at those questions. So Stephen and Julie are going to present for around about 40 minutes or so, and then we'll have a good chunk of time for a Q&A, which Leanne will moderate. So yeah, just a reminder, if you do have a question at any time throughout the presentation, please drop it in the chat function, and both Harry Lovelock and myself will sift through those and make sure Leanne's got them. So without any further ado, I'm going to hand over to our CEO, Dr. Leanne Begley, to officially welcome you all. Thank you, Leanne.
Thanks, Locke, and welcome everybody. We've had over 160 registrants for today, and it says something about how important this milestone is, I guess, for the mental health sector. I'd like to begin by acknowledging the country that I'm on today, which is Wurundjeri land, the Kulin Nation in Melbourne, and pay respects to elders, past, present and emerging, and also to people who've joined us today who are from those First Nation communities, and a special acknowledgement to them. I'd also like to acknowledge consumers and carers today who have clearly informed this report. It's exciting to see. It's a credit to people with lived experience that they've found ways to inform this report, and to Stephen, Julie and Harvey for listening and including them and their views. And I would like to acknowledge them for the contributions. So, and welcome to all of you and our members and our stakeholders in across Australia to listen to and engage with this report. Mental Health Australia's approach has been to invite Stephen and Julie to speak to us and talk to us about what the report says. So that's a summary, I guess, of what the report is saying to us. In the next couple of weeks, we'll also invite you to a webinar on a what's next approach with the Department of Health and with Christine Morgan, the CEO of the National Mental Health Commission, to talk about where to from here and the next steps, if you like. And we're looking forward to having that conversation. But today, we're really wanting to hear from Stephen and Julie about where they got to with this report, what are the highlights and issues that they would like to share with us. And I just also, before I hand over to them, would like to thank them for an amazing piece of work. This is a really very challenging area. We work in it, we respond to it, we experience it, and it's so important to people. And I'm sure that you'll agree with me that it's a landmark in terms of the progress in our sector for the next steps of reform. So thank you very much for making time, and we look forward to hearing from you. And I think I'm handing over to Stephen, am I? To start with, yes, thank you very much.
That's correct, thanks Leanne. Before starting, I also would like to acknowledge the traditional owners of the land that I'm on today, the Irukandji people, and pay my respects to elders past and present and emerging. I'd also like to acknowledge those with lived experience of mental health who have joined us here today. Let me just get the share screen going, which is that one. And hopefully you all now have some slides in front of you. Harvey Whiteford, who was our Associate Commissioner, is unable to join us today, but Julie and I are more than happy to answer your questions after the presentation. I'll keep the presentation to about 40 minutes. It's going to be fairly quick. In a sense, we are summarising a report that is over 1,400 pages once you take the online appendices into account. So think of this as a bit of a cheat sheet, but one of the things I would really want to emphasise is that when thinking about the issues that particularly interest you or your organisation, I strongly suggest you have a read of the overview, have a look at the 21 recommendations, but then have a look back at the base chapters to see how we got to the positions we got to, and they're quite detailed. I'll run quickly through the process that we've had to get to today. Then what I'd like to do is run through our broader findings, including the costs of mental health to Australia, look at our reform areas, and then talk briefly about the costs and benefits of various reforms before looking at next steps. First on process. It has been almost exactly 2 years between the time that we received the terms of reference and the final report was released by the Prime Minister on Monday. So it has been a long inquiry. In fact, from the Productivity Commission's perspective, it is the largest inquiry the Productivity Commission has ever done. It's larger in terms of page numbers, it's larger in terms of input, such as submissions and online comments. It's larger in terms of the hearings. So we went to many places in Australia and we heard many stories around Australia. And I really, again, would like to thank those consumers and carers who shared your stories with us. And it took many people a lot of courage to come out and state their stories to us. But we could not have written this report without the input of consumers and carers. It simply, well, the report couldn't be written, it would have been wrong without that input. And we really do thank you deeply for that. Particularly for the input post-draft. We recognise post-draft that there are a significant number of areas that we needed to tighten up. We need to make sure that the message was clearer, and hopefully you see that in the final report. So hopefully you see input going back to and including the webinar that we had on the draft report for Grace Groom, oration and so on. So again, thank you to the Mental Health Australia members for your input. Key findings. These are numbers that I'll whip through quickly because they're very familiar to you. Around half of all Australian adults meet the diagnostic criteria for a mental illness at some point of their lives. Almost 1 in 5 meet the criteria in any given year. The Prime Minister referred to these exact same numbers when releasing the report on Monday. The importance of this graph is that it shows the distribution of the Australian population, with those around 4 million people in any given year facing either mild, moderate or severe mental health issues. There are obviously significantly more people who have mild issues. One of the things that we try and highlight in our report is that if we look at healthcare, there needs to be improvement right across this spectrum, and that includes the people at the mild end of the spectrum. But too often those people try and manage their mental health themselves, often relying on friends, family or Dr. Google. You'll notice that one of our main recommendations, or a set of recommendations, relate around a digital platform because we think we can do better than Dr. Google. And we talk about the low intensity care gap in the report. We also have the moderate and severe groups, and with this audience should all be well and truly aware of that missing middle service gap, the lack of services between basic primary care, the GP, and the emergency department, so that when individuals who are living in community need some extra support, they often find that as their mental health is deteriorating, they don't have the primary healthcare support, they don't have community support, and the next stop is the ED. And that missing middle gap in services, both health or clinical services and community services, is something that's a key element of our report and our findings. Again, one of the things that most of this audience would be well and truly aware of is that mental illness has a high cost. And it's important to understand the basis of the high cost. And that is that, like many physical chronic illnesses, mental illness occurs and is prevalent early in life in many situations rather than later in life. So when we're thinking about the costs of mental ill health, we need to recognise that of those adults, around half of Australian adults will have meet the diagnostic criteria for a mental illness at some stage in their life. Around 3/4 of those will have their first symptoms before 25 years of age. So that means that this is a chronic illness that can run through life. And if the relevant supports are not there for an individual, it can impact upon their education, it can impact upon their employment opportunities. For example, their training to be able to engage in the apprenticeship system, for example. And it affects their ability to be engaged in the community right throughout their lives. And that is one of the underlying reasons why the cost of mental health is so high in our community. And these are the cost numbers that we have here. We have up the top the economic costs. It's sort of odd for an economist to say this is non-economic language. To an economist, all of these costs are economic costs. However, in everyday language, when we talk about economic costs, we're sort of thinking, oh, what's the effect on output? The stuff that we produce, the stuff that comes out of factories and fields and offices. So the top group is that, factories, fields and offices group. Around $43 to $70 billion, 16 billion in terms of the healthcare and other services, 15 billion for informal care down the bottom of that orange group, coming from a study out of the University of Queensland in 2017. The 12 to 39 billion in lost productivity. There's a fair range in there because it's very hard to estimate. Particularly presenteeism. So what's the loss of productivity for people who have mental health, but they're able to continue in employment in the workplace, but they're not operating, they're not functioning as well as they would like, and trying to get a number on that. So there's a fair range in there, but you add those numbers up and they're significant. However, you look at the bottom and you look at diminished health and reduced life expectancy, and that's more than double those other costs. And that is a true economic cost. That is a cost which reflects a reduction in the quality of life for people who are living with mental illness. It also reflects the life expectancy gap. For example, we know that people with severe mental illness die approximately 10 to 15 years earlier on average, usually due to physical comorbidities. And that is a real cost to our community. Add these numbers up and, they come to a very large number, but, saying, well, 200 to 220 billion, it's sort of a meaningless number because it is so large. We try and put it in perspective. For example, if you think of everything the Australian economy produced last year, this number is equivalent to about 10% of everything we produced in the economy last year. In other words, it is a really, really big number. Now, I want to stress that not all of these costs are going to be able to be avoided. We are not going to be able to eliminate mental ill health, we recognise the Productivity Commission that there are a range of psychosocial determinants of mental ill health, including trauma and including early childhood or trauma early in life, poverty. People with lower incomes have higher level of psychological distress. We know that and recognise that. There are a range of external stresses. We do not try and solve those problems in this report. So one of the criticisms we had at draft, and we've already started getting it at final, is people saying, but you haven't solved climate change. Unless you solve climate change, you won't be able to address underlying stresses. Or you haven't solved poverty. Unless you solve poverty, you won't be able to address those underlying stresses. No, we haven't done those things. It would be great to achieve. But this is a report on the mental health system and how we can improve that system. We had to draw boundaries around there, so apologies for that. I hope you see, though, at the end of this presentation, that when we look at the potential benefits of reforms to mental health, no, we're not going to be able to eliminate all 200 billion. We're not going to be able to eliminate even the majority of that, but we are still going to have really, really significant benefits to Australia through reform of the mental health system. So our reform areas. It's important to understand the underlying rationale, the underlying approach that we took in our report. And this is something we really didn't explain well at draft. So in a sense, it hasn't changed since draft, but hopefully you'll see, particularly if you read the overview, you'll see that we've really tried to make it clear that what we are after here is a person-centred mental health system and what we mean by that. Some of you will have been to other presentations that I've been involved in. I've said, well, from an economist's perspective, it's obvious that you want a person-centred system, that the mental health system needs to be designed for the consumers. It needs to be evaluated on the basis of the outcomes for consumers. Where possible, those outcomes need to be judged by the consumers themselves. But you can't go past. The gold standard is that the consumers receive the relevant services, they evaluate the services, they have a choice over services, and they say whether the services are working or not, because nobody else can. Unfortunately, too often in not just mental health, but in the health system more generally, we have views that, well, the system should be designed for clinicians, for example, or the system should be designed for service providers. No, we fundamentally think that is wrong. We're after a person-centred system. The system must be designed for the benefit of consumers and carers and evaluated, judged on the basis of the outcomes as perceived by the consumers and carers. One area that you'll see we've changed in our report is our framework that we use to really summarise our approach to the report. In our draft report, we used a pretty sort of a modified clinical step care model. And it was pointed out to us really quickly post-draft that that was wrong, and we recognised that that was not the best way of thinking about community supports and clinical supports. So when you look at our report and when you look at the overview, you will now see that the approach that we've taken is to recognise that consumers need to have a choice over a range of clinical and community supports, that the particular mix of supports that is right for an individual consumer will depend on that consumer and what their preferences are, and for some, and the stage of their illness. And for some consumers, yes, they will need high intensity clinical services, and yes, they will need high intensity community support. But for some other consumers, they may need, for example, significant community support, but they don't have that particular clinical need, or vice versa in certain cases. So hopefully we've been able to capture the fact that you can't put clinical above community or community above clinical, that it is that mix of services, that matrix, as I tend to call the framework we've got now, that matrix of services that needs to be available for consumers to make sure that they can stay healthy and recover in community. Second point, before we move on from here, and I'll let you read through particular bits, whole of life approach, early intervention and prevention, both early in disease and early in life. Maintain health and recovery in community, which is what I was just referring to, the framework. Get the right mix of clinical and community services, and value services as valued by the consumer. One final thing to mention though, before moving on from our framework, from the way we've approached the report, is that we need to recognise stigma, and we need to recognise the barriers that stigma create to effective service delivery. Because stigma exists not just in the broader community, stigma also exists in parts of our healthcare system. And unless we deal with that stigma so that consumers with mental health issues are able to access the care that they need in a supportive environment, then we're going to keep hitting that barrier of stigma, which I think will significantly retard progress in our mental health system. Our reform areas. So we've got 5 reform areas: prevention and early help for people, improve people's experience of mental health care, improve support within the community, equip workplaces to be mentally healthy, and instill incentives and accountability for improved outcomes. What I want to do is very quickly run through at a very high level our recommendations, particularly our priority recommendations in each of these areas, and give just one example in each area. Again, obviously there's going to be a whole range of actions that fall into each of these areas. Our final report contains 21 recommendations with 103 actions. And hopefully it provides a very clear roadmap for the government to be able to implement reforms. And again, I have to thank some of the people who are in this webinar for the feedback that we got post-draft. We have done a lot of work between draft and final in trying to make sure that it's clear what's priority, what's important, but not necessarily a priority. And I'll talk about the way we prioritise in a few minutes, and to provide that roadmap for government. And that was really based on important feedback. In our draft report, you will see, getting up towards 100 draft recommendations. And we heard back both from government and from people in the sector that just simply dumping 100 recommendations out of a report really isn't helpful. That the sector and the government need a roadmap for reform. And hopefully that's what we've got in our final report. As I said, 21 recommendations that include those 103 actions, and try to focus in on individual areas and say, well, this is prioritised, do this first, and so on. So prevention and early help for people. Support the mental health of new parents. 2 things on that, and this is one I'll spend a little bit of time on, even though it's not an example. First thing is that the government has already made some moves in this direction in the last budget. Second is that those of you who remember the draft report and some newspaper headlines following draft report, I think it was therapy for tots or something like that, for Daily Mail ran with.
Australian, Stephen.
No, I'm thinking back draft. So, but you're right, Julie. Unsurprisingly, some of our recommendations will be mischaracterised. And there was an article in The Australian, obviously a journalist who was looking for a different angle, who tried to say, well, again, they're trying to put tots on mental health prescriptions. No, that's not what our recommendation is about. If you're interested in the recommendations for health, help for new parents and the social and emotional development of school children. Please read that part of the report. What we're aiming for there is to look at early childhood and to think about the voluntary health checks that occur and before a child enters preschool, and really just to check on their social and emotional well-being. And that's important because often, well, we know that those first 1,000 days and that preschool period is critical to a child's development. We also know that just checking on the social and emotional well-being of a child, when something's going wrong, it will often be that something's going wrong at home, and having that conversation with the parents and working out the potentially deeper issues can be really important. So support for the mental health of new parents, social and emotional development of school children. You'll see again, that's come on quite a way since draft report. National stigma reduction strategy. I've already mentioned the issue of stigma and the barrier that it creates. I'm going to come back to follow-up care for suicide attempts and empower Indigenous communities to prevent suicide because the statistics are quite clear. The suicide rate among Aboriginal and Torres Strait Islander peoples, it's up to 3 times higher than for the general community in some states, and nationally it's twice as high. But follow-up care after suicide attempts, that's the example that I want to focus on, the particular policy. Why focus on this one? This is a good example of what I'm going to call a free lunch policy. And this is a very, very odd space for the Productivity Commission. Generally, economists, and most of the people involved in the Productivity Commission team are economists. Economists are very, very skeptical about free lunches, about situations where you can say, well, there's actually benefits from changing this policy where the expenditure is less than the savings from changing that policy. But there are many of these in the mental health system. And you'll see that in our report, we've said, well, why aren't people adopting these policies? Why aren't governments adopting these policies? And you'll see that a significant part of the 3rd volume of our report looks at the incentives in the system, the incentives facing government, and the need for an improved approach by government so that we can get these policies in place. But this is a simple policy. It was one we referred to in the draft report. It's a situation where simple follow-up after a person has attempted suicide, either follow-up after they leave hospital, or in some cases a community health clinic or a GP. The cost of this follow-up, the discharge planning and follow-up, comes to about $2,000 to $6,200 per person. But the returns in terms of reduced future attempts of suicide are at least twice those costs. Because this is a group of people that we know are in a higher risk of a future attempt of suicide, and simple follow-up planning, simple following up with the individual in the weeks after discharge can help avert those attempts, and it can save lives and it can lead to significant community benefit. So that's an example of one, and you'll see a number of those through our report. Improve people's experience with mental health care. As you would expect in a report of this size, there are many, many actions and recommendations relating to mental health care. The first really look at creating that person-centred mental health care system. Part of that is recognising that for many people, the GP is the current gateway through which they enter the system, the clinical system for mental ill health. There are GPs out there who do a fantastic job in assessing, referring, helping the individuals that come through their door. But that's not uniform, and some GPs need some more help. Further, I mentioned the group who tend to be relying on Dr. Google. That group needs more than Dr. Google. So what we recommend is a digital platform which will include, among other things, an assessment and referral process, a supported assessment and referral process, which can be used by individuals directly, or it can be used by GPs so that they have more assistance when a consumer comes through the door and needs their help. And the aim is to help people find the services that are best for them. Second point on there is to identify, support and include family and carers as part of mental health care. One of the things that, it reflects a culture in our healthcare system that even if a consumer says, yes, I want my carer, I want my family to be included, too often that request gets ignored. And the people who actually have the most information about the consumer, other than the consumer themselves, are often left out of the conversation. And so we want to make sure that they're brought into that conversation when the consumer wishes that. Second group down there, we're worried about the prescribing practices that occur. And in our hearings, we heard some pretty heart-wrenching stories about people who had been placed on mental health medication without proper warnings about side effects, and that led to tragic consequences. Around 5 million people a year see their GP for mental health issues. 6 in 10 leave their GP with a prescription for a mental health medication. In contrast, only 2 in 10 get a referral to either face-to-face therapy at a psychologist or psychiatrist. And almost no one leaves the GP with a referral to, for example, supported online care. We'd like to change that, and we've got recommendations to changing that mix. I've mentioned the life expectancy gap. That needs to be addressed. We need to make sure we have continuity and coordination of care. That again is addressing the missing middle, and we've got a range of actions relating to that. For that low intensity gap, we see that there can be improvements in use of online treatment, telehealth, group therapy, access to supported online services that can provide more options for consumers in terms of low intensity clinical treatments. Part of the reason why that's important relates back to the workforce, because we need to make sure that not only are we dealing with that low intensity gap, but we are also able to use the workforce, the clinical workforce that is hopefully freed up to be able to move that workforce to deal with the missing middle gap. So let me focus on a couple of these recommendations, EDs and so on, you can look at for yourself. This is the diagram you'll see in the report. This diagram, in a sense, captures that low intensity and the missing middle gap. On the horizontal axis, we have service intensity going from low intensity clinical services to higher intensity. On the vertical axis, we have numbers of people. And the blue line shows where the current services are. What we really need is that blue line to follow the orange line so that consumers are getting the services that they need when they need them. So we need to improve the low intensity services. There are some workforce issues in the middle, but we actually have quite a large population of psychologists in this country. There's some shortages in psychiatrists, there's shortages in mental health nurses. And we have recommendations looking at those. But we need to make more options available for those who walk through the GP's door for the first time or dealing with mild or moderate mental health issues. And we need to make sure that the resources are moved to community services, such as community ambulatory services, so that people in the missing middle, people who have more significant clinical needs, get those needs met in community, but they don't end up in emergency departments. Third area is improved support within the community. There needs to be more community support services. They need to be looked at, not just on a national basis, but on a regional basis, and recognising that the needs for services differ significantly across the population and across different areas of Australia. We need to make sure that we've got a regional planning, a regional commissioning, and a regional evaluation process that ensures that the community support services that we know are needed and are not currently there, we need to make sure that they are there and that they're operating effectively. We need to make sure there's no discharge from into homelessness from care, so that we avoid that cycling in and out of hospital or other institutions. We need to make sure that our first responders have appropriate support when responding to mental illness related incidents, and legal representation. That's the example I'm going to use on here. So let me just move on to this. Legal representation before mental health tribunals is not one of those recommendations we were able to put a dollar number on. You simply can't. But the data is pretty clear because we have different practices in different states, and we're able to compare that data. And yes, it's a messy process. So those of you who want more details, you can see that in the report. But it's pretty clear that having legal representation at a mental health tribunal matters. That the relevant individuals are more likely to attend their hearing, they get a longer hearing, and they often get fewer orders for compulsory treatment that the consumer is against the consumer's wishes, or shorter periods of compulsory treatment. So this isn't something we're able to put a dollar figure on. It's just something that's the right thing to do, and it matters. So that you'll see again in our report, there's recommendations and actions around this legal representation. Equip workplaces to be mentally healthy. We need to make sure that psychological health and safety is raised to the same level as physical health and safety in workplaces, and that it is taken seriously. We've got a range of recommendations around workplaces. The one that I'll focus on very briefly is no liability for clinical treatment for mental health related workers' compensation claims. We know that mental health related workers' compensation claims lead to individuals being off work for longer. They lead to, in a sense, conflicts within the system, as they are more often contested than physical compensation claims, and they can delay treatment for the individual. And the delayed treatment means that they're less likely to get back to work. So a simple change that we flagged in draft and have followed through in final is saying, well, if you put in a mental health related claim, you can access the relevant treatment immediately on a no liability basis. We did the numbers for it. It can easily be paid for by a very small increase in workers' compensation premiums, less than 1%. I think the exact number is about 0.7%. So we think this is, again, is doable, and we think it'll make a big difference to individuals who face mental health issues in the workplace. And finally, instill incentives and accountability to improve outcomes. Best way to explain these is actually to flick over to the examples which cover the first three, and I'll flick back to this slide in a second. We see the incentives and the whole process from government right through action to evaluation as depending on cooperation between levels of government and making sure that we have the right processes and institutions in the place at the right point of time. So we start off noting that we need a new whole of government strategy. That is a strategy that involves the states, territories, and Commonwealth government. We need a plan by our governments to work out who is responsible for what, who is going to fund what. And as the Prime Minister noted on Monday, our reforms will require all levels of government to get out the chequebook. And so we need to make sure that there is alignment between governments. We need to make sure that at that regional level, that the service provision is working. So at a regional level, what's missing? What dollars are needed? They're provided to make sure the services are then expanded and provided, and that operation at a regional level is transparent and is evaluated to make sure whether it's working or not. That means that we have to have both evidence-based programs at the regional level, but it also means that we need to make sure that there's evaluation of whether what's being provided at the regional level is in line with the needs of the consumers at that regional level. And finally, if we're going to have that monitoring, reporting and evaluation, we need those processes in place. And we see an enhanced role for a National Mental Health Commission, for example, and a number of other bodies, but the National Mental Health Commission being the main one, to provide that evaluation function. Let me just come back to this slide though. Couple down at the bottom. There needs to be improved consumer and carer participation and advocacy at all levels of the mental health system. Far too often it is tokenistic. There needs to be real input. And, you know, again, to an economist, this is sort of obvious. You wouldn't go out and design a car without asking people who drive cars what they would like. If you do that, you end up with something that the consumers don't want. The same holds in our mental health system. If we're not asking the consumers and carers what they want and taking it into account, we cannot end up with a person-centered mental health system. It's just impossible. So you'll see recommendations on that. And that evaluation culture, making sure that when we bring in new services, when we fund new services, that we work out how do we tell if these services are working. The gold standard is, do the consumers think they're working? How do we get that data? How do we ask consumers? And then how do we evaluate these services? If they're working, great, we can spread them more broadly. If they're not working, what do we bring in their place? Costs and benefits. I'm not going to spend long on this diagram because I've essentially used up my time. You can read more about this. This is essentially looking at the improvement in life. So you'll notice on the horizontal axis, the QALYs, quality adjusted life years, versus the benefits or costs on the vertical axis. Thing that I really want you to note here, and again, there's a lot of information about this in the appendices to the inquiry report. The thing that I really want you to note though is that there's significant numbers of sets, and often these are sets of recommendations that we've been able to look at here, above that zero line. I mentioned earlier on that follow-up after suicide was this economic oddity, a free lunch. Those things that are above the zero line are those policy groups where we have looked at them and the benefits from those policies, straight out economic benefits in terms of saving to government, saving elsewhere in the system and improved participation, that they outweigh the cost. And you'll see there's quite a few of them. They stress why we need that whole of government approach, because what's happening at the moment, why aren't these being used? Well, often it's because one level of government is having trouble coordinating with another level, or it's an expenditure in housing that benefits health. And those we've been told by some state treasury, that those sort of cross-portfolio programs are very hard to implement, even if there's a net benefit there. Now, that doesn't mean you just want to concentrate on the ones above the line. The ones below the line, such as school age support, are still highly beneficial because they improve the quality of life significantly. We've got different levels of evaluation here in terms of measure of quality adjusted life years. Details are in the report. We prioritise the reforms on the basis of the potential to improve lives, the benefit cost ratio, ease of implementation, so are they easy to bring the reforms in, and the sequencing. What needs to be done first? And overall, we get the figure that all reforms that we recommend can lead to benefits of around 18 billion in terms of quality of life. They will lead to savings of 1.3 to 1.7 billion, and they will increase economic participation by up to 1.3 billion. Yes, they will have a cost. They will have a net cost overall. That net cost is down there at around about 4 billion. We can get to about 90% of those returns by just focusing on the priority reforms. That doesn't mean that we should just focus on the priority reforms, and I want to emphasise that. What we're showing here is that our reforms overall have a significant benefit. We can get most of the way there by priority, but that doesn't mean we should just dismiss, for example, the extra 7,000 quality adjusted life years that we can gain by going further, or the extra approximately $500 million in savings that we can get by going further. But it does suggest that we certainly want to start at least focusing on those priority reforms. So what's next? I've mentioned on the way through, but the government has already started to move on some of our recommendations. Telehealth has expanded due to the COVID-19 pandemic, but I think its benefits, the sort of benefits that we highlight are now much more broadly recognised. Additional funding for children and young people's mental health was in the budget. The Prime Minister announced that they were moving forward with the intergovernmental strategy. The government has said that it's going to consider not just our report, but also other inputs such as the National Suicide Prevention Task Force, and that they're going to be consulting until February 2021, aiming at a comprehensive response to our report and these other inputs on May 2021. So what's the next step for the people listening to this webinar? I would strongly suggest that you become part of this process, part of this consultation, because that's the best way that we're going to get change going forward. I would suggest that with our package of recommendations, that you're very careful before you say, well, my favourite recommendation isn't a priority, so I'm going to really push that and downplay the priorities in this area. Or, the evidence didn't come in for this recommendation, but I really like it, or this policy, I really like it, I'm going to push that. I'm just going to try and cherry pick bits. So yes, we need extended sessions for under better access, but oh, I don't like that idea that it needs to be evaluated to make sure it really is making a difference. So we'll just pick one bit without the other bit. The reason why I stress that is not just because we think we've done, a pretty good job of trying to set out that roadmap already. But the risk is when you start to cherry pick is that you start to create division in the sector. And the division in the sector will be used by those who don't want reform to try and stop reform going forward. And we all know that there are groups out there who would prefer reform to fail. So that's it from me. Apologies, I've gone on for about 5 or 6 minutes longer than I'd hoped.
Thank you, Stephen. Thank you very much. And Julie, did you want to add anything before we went to some questions, of which we have many?
Leanne, the only thing was to share in Stephen's thank you to the sector. You've made yourself so available to us, and to acknowledge that for many of the people that come forward, that wasn't an easy thing to do, and to thank them for participating.
Thank you, Julie. Look, what I'm going to say to everybody is, and I'll just check with Stephen and Julie, you're right to go to 11:15.
Yep.
Is that all right? So what I might ask you to do is make your responses to these questions and queries, concise so we can get through a few, but also to say to people online, we're very keen to have your input. So if the question doesn't get asked or we don't cover your issue, that's fine. Our team is putting together a first cut response that will come out with my update on Friday, and then a more detailed analysis over the next couple of weeks. And of course, we value the input from the sector to make sure that it's really a clear analysis. And so don't worry that your commentary is being missed. It's absolutely not. And our team's all over that. Look, the first question I might ask is the one that came up first, which is that just the report's acknowledging the critical importance of early years, including before school, but it doesn't seem to recommend much additional funding for early childhood before school, apart from more work with parents. Why not recommend greater investment in early years for children experiencing trauma and multiple adverse childhood experiences?
Well, I'll sort of have a start at that, Stephen. One of the things I'd say about funding is that funding obviously is a matter for government. So what we've tried to do is to set out the case where particular areas need priorities. And in terms of funding for early childhood, we certainly have said, look, these are priority areas. We'd like, for example, in the schools, for the schools to have a wellbeing measure that we can actually track against. So I guess my answer to that is that we haven't gone down saying you must fund this or you must fund that. We've said that these are priority areas because obviously these are matters for government, but we've tried to set out the path forward for that. Stephen, did you want to add anything?
Yeah, I mean, I think if you take it at a broad level, the three, the support for new parents, the preschool social and emotional wellbeing checks, and then the social and emotional wellbeing programs in schools. When we did the numbers, alas, we're thick-skinned economists in general. The support for parents and the social and emotional wellbeing programs in schools simply came out as higher priorities than the early childhood social and emotional wellbeing check. So they haven't disappeared. They're still in the report, but yes, you won't see quite the emphasis that you may have seen at draft on those particular or that particular part of the recommendation.
Thank you, Stephen. I'm going to combine a couple of questions here. We're getting quite a lot of questions around the governance, between states and territories and the federal government, the role of PHNs and the coordination functions. Here's one. Does the report recommend a resolution to the lack of clarity and responsibility for which level of government is responsible for funding community and psychosocial support? So this is coming from this idea that navigation works when there's services to navigate to, and what are the funding mechanisms that might need to be invested?
We certainly do have something to say, and at the risk of then referring to the report, in recommendation 23, we certainly say that state and territory governments should take on sole responsibility for psychosocial supports outside the NDIS. So we certainly, where we could, we were asked quite particularly to think about clarity, and we have attempted to do that in some areas. Okay.
Stephen, did you want to comment on that as well? No? Okay. Does the report include any recommendations for significantly increased non-clinical, so peer-based lived experience leadership? There's both provision of services and also managers with lived experience.
Stephen, I might pass that to you. We're quite strong on peer workers, so I might pass.
So we have. If you look at the workforce parts of the report, and I guess I mentioned on on the way through. But really there's the two parts there of a clinical workforce, but for the community services, the peer workforce and the increased community workforce. So there are a range of recommendations there. Unlike Julie, I was just very impressed you was able to say, oh, recommendation 23, that's the lawyer. So, yes, we do have recommendations. Or again, remember, sometimes you have to go down below the high level recommendation down into the individual actions to find the relevant bit. So you'll notice the way that we've presented it is you often see one line with a reference to, you know, action 54 and 73. And you actually have, when you go and see those, you'll say, ah, okay, action 73. Unlike Julie, I'm not going to pretend that that's the correct number. That's relating to additional peer workforce and so on.
I also,
go on, sorry, Julie.
Leanne, I know you asked us to be brief, but one of the things about peer workers that we really did highlight was the barrier of their acceptance by clinicians, and we certainly recommended that more work needed to be done to amongst clinicians for the role and value of peer workers. So we've certainly picked up on that. Sorry, Leanne. No,
that's fine. So we have a number of people thanking you for your analysis and recommendations through the process. For community-based psychosocial support, could you please summarise how many people need it now? This is going back to your detailed memory of numbers. How many people need it now? What additional investment is needed? How should it be funded? What level of government should be administering it?
Do you remember the number, Stephen?
The numbers are in the report. We've worked off the relevant planning frameworks. So, for example, you know, I'll just pick community ambulatory because that's one that I can remember and it's worth highlighting as an example. We make, or we have the estimates for the increase in community ambulatory workforce that is needed. We also note, though, with the community ambulatory workforce that the current way that workforce is funded and organised means that, quite frankly, they're not spending much time, the clinical workforce there aren't spending much time with consumers. And you'll see the number 29% is in the report, being the estimate nationwide for what percentage of their time is spent with consumers rather than doing paperwork or whatever else. That's less than half of the target in the National Mental Health Planning Framework. So, for example, with that particular group, you'll see, yes, this is the increase in the number of workers and the number of worker hours that is needed. We then have two estimates, one based on under current 29% time with consumers and one under with time with consumers based on the National Mental Health Planning Framework. So again, we've tried to be as comprehensive as possible because there are reforms there that can actually improve the availability of that work.
The incredibly helpful staff who have not left us, Stephen, tell me that the answers to these, Leanne, lie in chapter 17.
Thank you. Excellent. All right. Can I move us to PHN, LHN cooperation? If PHN, LHN cooperation fails to improve outcomes is a line from your recommendations. So how's that going to be measured and what's the time frame for the decision? And the question is, has this essentially put regional commissioning off the table?
Do you want me to go first on that, Julie? Yep, okay. Mainly because in some other presentations, there's been a slide exactly on this. So if you go back to our draft report, we had the rebuild option and we had the renovate option. The renovate option being working on current PHN, LHN cooperation, rebuild, let's start again with regional commissioning authorities. Our feedback from draft was pretty clear that in some parts of Australia and some Australian governments really do feel that a rebuild is needed. But in other parts of Australia, you know, the cooperation is actually starting to work and good things are starting to happen on the ground. And the feedback from consumers, for example, in those areas were, well, we're just starting to see progress. For God's sake, don't throw out the progress we're making and put us back to square one again. So that's why we've changed our approach to say, well, if either a state government wants to rebuild, it really thinks it's not working, they should have that option. If they feel that there is the PHN-LHN Corporation is starting to work, they should be allowed to let that continue, subject to the PHN-LHN clearly assessing local needs, the PHN-LHN clearly providing the services to meet those needs, and then their performance being evaluated. And again, that's one of the roles of, I think it's the NMHC in that case, but
it is, Stephen, it is.
To evaluate and report back, is this regional commissioning being successful? So regional commissioning still underpins the whole approach, and it's got to, because what's good in Glen Iris in Melbourne is not necessarily going to be good in where I am in Cairns in Queensland, and almost certainly is going to be completely inadequate in the Kimberley. So you need that regional approach. That's still the approach that we think has to be taken, but you need to make sure that there's the flexibility in the approach. We don't want to throw out stuff that's working well, and there has to be the clear planning, clear transparent planning, the service provision and the evaluation. And if PHN-LHN Corporation isn't working, you've got to go to that regional commissioning authority.
Okay. Julie, did you want to add anything else to that one? No? Okay, so if we could move, I'm just trying to cover different topics here, recognising I'm jumping between things. There's an issue related to and feedback related to the cooled populations. How do we ensure that people from cold backgrounds are included in all the recommendations and actions, acknowledging that you have considered them in your report?
Well, I suppose the answer to that really is that we always want the services that are delivered to be culturally capable, and we have a strong emphasis on that in service delivery. In some cases that will mean upskilling for some of the practitioners. We also felt quite strongly about consumer representation and consumer representation in the broad, so it was involving people from those communities. The other thing I'd also say is that we have produced a number of fact sheets, which we didn't mention before, which are on our website, and we've also done the CALD ones in a number of languages so that they were as accessible as possible.
Thank you. Let's move to the recommendations or the powers of the state-based mental health commissions that were recommended to be established. Can you talk to us about those?
Well, I suppose in the broad, we were not prescriptive in this space. We simply observed that there were a range of different functions in particular national mental health commissions, but we did observe that in some states, for example, they didn't really do sort of the policy or the outreach, and they had dispute resolution. So, Stephen, correct me if I'm wrong, but I don't think that we're actually prescriptive about that. But we thought the institution of having those was actually quite an important point.
Yeah, the key is the National Mental Health Commission, which is the overarching body, which has, under our recommendation, statutory independence, and can take that overarching role of evaluation, working out what works, and then with the assistance at the state level, making sure that what works is available to those consumers who seek those services.
Okay, so there is a couple of comments about the place of COVID in all of this, and what happens after pandemic. Or, you know, post-pandemic, and the long tail that we're all expecting in mental health terms as a result of what's been such a challenging year. So where did you land in terms of, you know, COVID and your future reform agenda?
I think one of the things that I would say is that we've worked to build a health system, mental health system, that can flex up and flex down. because whilst we're experiencing COVID at the moment, there are other shocks to the system. We had the bushfires early in the year. So our vision, if I can put it that way, was that we would be able to ramp it up and ramp it down. So it's really in the system design.
Okay.
The flexibility of services, for example, because we don't want to just, we're asked this question quite often, and we don't want to just respond and design a health system to respond to the current pandemic, because in 10 years' time there'll be other stresses, other pressures. We want to make sure that a health system can respond to those, a mental health system can respond to those as well. So it's that flexibility that you need rather than a design for a particular problem.
And I think one of the, if there are any sort of good things, if I can put it like that, and I live in Melbourne, everyone, to come out of COVID, is that we've seen reform move really, really quickly. We were very keen on telehealth early on because we saw that as part of the solution for regional and rural Australia. But, the government, because people couldn't get out of their homes, actually had to respond very quickly to that.
Look, I'm going to ask you a kind of winding up question, I guess, because, picking up on consumer experience and KPIs, evaluation, and those sorts of areas that you've definitely addressed in the report. If all your recommendations were implemented, what would the mental health system look like from a consumer perspective in 10 years' time?
Well, that's such a big question. First of all, we would never presume that we would have all our recommendations implemented. Those are clearly matters for government. But I'll start with a really simple premise, which was the one that Stephen started with. If the consumers don't achieve what they need for the system, then why do we have all of these things? So it's really about the empowerment of consumers to get the services they need when they need them. And that would be the big comment that I would make.
Yeah, I think I'm going to actually pick an answer that comes from one of the reformers, Richard Ledyard, in England, in this area. And he said that one of the ways to think about mental health and the lack of services, the reluctance to talk about it, the stigma, is to think about how we used to deal with some physical conditions like cancer, when it was just the case where you got cancer, you died. There was no treatment. And you just didn't talk about it. You didn't have services for it. And he said, well, in a sense, in the UK context, what we've got to do now is recognise that there is so much that we can do for people who have mental ill health. There is so much that can be provided for them to choose to live fantastic lives. And that's what I hope we achieve. And if our recommendations, in full or in part, if a lot of our recommendations are put in place, hopefully in 10 years' time, we will be having open conversations about mental health. It won't be the situation that I found with this report, which I found quite stunning. And I've mentioned this to a few people, but when I started this report, I'd talk to people and they'd say, oh, you may not have known, but my brother's got schizophrenia. Or, oh, you probably don't know, but my mum took her own life. And everybody that you talk to is touched by mental illness, but we don't talk about it. So hopefully in 10 years' time, not only will we see a change in services, availability, a focus on consumers, we will see a social and a cultural change in the way that we deal with mental ill health.
We just lost you a bit there at the end, Stephen. That's all right.
Social change.
Well, I should say, Leanne, part of this is that Stephen and I and Harvey and the team, it was one of those inquiries, if you indulge us for a moment, we feel really passionately about the subject matter. It was a bit heartbreaking in some of the hearings that people came to us and said, it's the first time I've been able to tell my story. And we thought, we're the Productivity Commission. We're usually very interested in numbers. So, I sort of joined with what Stephen said.
Well, I think it would, on behalf of the sector, it's really important to acknowledge the listening and that you've undertaken both before the draft report and after the draft report, in terms of the feedback and the way that you've sought to synthesize and honour that feedback, and listen to the sector too, and providers and people living with mental illness and their families. And we're going to miss you, because I don't think we're going to be engaging with you any of it. It's been 2 years of collaboration, and we are going to miss you. And there's we're very grateful for your work. And I'm assuming that it's now over to government and to those of us in the sector to take this forward. And it's a great opportunity for us, a gift for us to use and now build our advocacy and change the system. So thank you so much. I'm sure that everyone will be joining me in thanking you for your time. Stephen spoke, he provided the Grace Groom oration last year as part of Mental Health Australia's offering to members. And this year, the Grace Groom oration will be given by Brendan Murphy from the Department of Health, and who has been the Chief Medical Officer, and he'll be talking to us. So please keep an eye out for that and come to that. You can come to the AGM as well, that'll be good. And it's on December the 10th. And please keep your feedback coming through to Mental Health Australia so that we understand and can incorporate that in our response and submission back to government about the next steps. Thank you again, all of you, for your time. Thanks, Locke and Harry and the team at Mental Health Australia. We look forward to seeing you all soon.
Thank you.
And thank you to Mental Health Australia and all the participants.
Thank you. See you later.
Thank you, everyone. And for those who are still on, the link will be coming around this afternoon to today's presentation. So thank you all.